Yeah, thank you, Taka, for that wonderful talk. It's a pleasure for me to introduce my friend and colleague, Professor Shinji Tanaka from Hiroshima University. So many contributions to colorectal endoscopy. He was my boss for many years on the CTNIG committee that developed the NICE classification and was the basis, I think, for the JNET classification. So Shinji, welcome, and you're going to give us your perspective on ESD in the colon. Thank you. You might be on.
You're muted.
Thank you so much, Doug and Norio. It is a great honor for me to be here in this very exciting event. From now, I'll talk about my idea. Please start my video. Today's my topic is colorectal ESD, its indication and for the case with severe fibrosis. This is my COI. This is a basic endoscopic resection strategy for colorectal tumor. Low-grade dysplasia in Western countries is benign adenoma, so piecemeal resection is permitted. On the other hand, high-grade dysplasia in Western country is actually intramucosal carcinoma. So en bloc resection is recommended to obtain detailed pathologic findings. Shallow SM invasive carcinoma should be also resected en bloc. Carcinoma or suspicious carcinoma should be resected by EMR or ESD, not by polypectomy, to get enough submucosal layer to judge the SM invasion. ESD should be selected for the lesion larger than 2 cm due to the limitation of the snare size. I will show you one case. This is a 2A plus 2C lesion with central elevation 25 mm in diameter. Central elevated part shows irregular pit pattern, so we can diagnose this lesion is carcinoma. We conducted hybrid ESD for this lesion. This lesion shows submucosal invasion under the central elevative part. If we conducted piecemeal resection, we might not diagnose the submucosal invasion. Like this, carcinoma or suspicious carcinoma should be resected en bloc. JGES has colorectal ESD and EMR guidelines. This is the second edition published this year. In this guideline, indication of colorectal ESD is described. Number 1, large-sized, generally larger than 2 cm in diameter tumor in which en bloc resection using snare EMR is difficult, although it is indicative for endoscopic treatment. In other words, early carcinoma or suspicious early carcinoma. Concrete cases as below. Number 2, mucosal tumor with fibrosis caused by prolapse due to biopsy or peristalsis of the lesions. Number 3, sporadic localized tumor in chronic inflammation such as ulcerative colitis. Number 4, local residual early carcinoma after endoscopic resection. If local residual tumor is benign adenoma, ablation is okay. However, it is carcinoma. Complete en bloc resection is essential because we have to get precise pathologic information. As shown in this slide, The number of colorectal ESD cases in Hiroshima University is increasing every year. There are many various colorectal ESD knives. Of them, my favorite knife is dual knife and IT knife nano. From now, I will talk about tips of colorectal ESD for the case with severe fibrosis. At first, to use ST hood. ST hood was developed by Professor Yamamoto. This hood is cone type and easy to enter submucosal layer and can make a good situation at the submucosal layer. Next, I introduce the SO clip for traction of the lesion. Counter traction of lesion is very effective to get a good situation to submucosal layer to dissect. Clip with string is also useful. However, colon is complicated lung structure and sometimes non-effective. SO clip can track the lesion to any directions. Key point to use SO clip is that spring tip should be fixed at the opposite side of the lesion, separately 2 folds distance behind the scope tip. This escapes the looseness of traction due to the progress of dissection. I will show you one colorectal case. This is standard case. However, sometimes it is difficult to enter to submucosal layer like this due to the existence of feeding artery or local fibrosis. In such a situation, SO clip is useful. At first, we grasp the edge of the lesion like this. Then, by another clip, we catch small ring of spring like this. Then, we fix at the opposite side of the lesion, around 2 folds behind the scope tip. By using SO clip, we can get very good view of submucosal layer. There is a mild fibrosis. However, we can dissect easily and safer. When it is difficult to enter to submucosal layer during colorectal ESD, SO clip is very useful. Next, I introduce the needling technique of dual knife. As for dual knife, even in needle-in state, we can dissect submucosal layer and effective to stop bleeding from small vessel. Because as for the dual knife, even in needle-in state, knife tip is a little extended from the knife tube tip 0.1 to 0.3 millimeter. This point is completely different from the flash knife. In a situation where the scope and muscular layer are almost vertically oriented, the risk of perforation is high in a needle-out state, but the needle-in technique is safer. However, even in needle-in state, we must be careful to avoid thrusting the tip of the knife to the colonic wall. Gentle, soft touch of the knife tip to colonic wall is important. This is a residual tumor in rectum after piecemeal EMR. As you can see, this lesion accompanied by severe fibrosis. Magnifying findings show no invasive pit pattern. However, biopsy specimen shows carcinomatous histology. So this lesion is indicative for ESD. This case is typical indication for SO clip. I will show you the procedure of ESD for this case. To use SO clip, at first we conduct the circumferential normal mucosa incision around the region where no fibrosis. After normal mucosa incision, we add submucosal dissection. For this perpendicular approach to muscle layer, dual knife needle technique is useful. Dual knife needling technique should be used under the normal mucosa, not under the region to avoid the overburning effect. Now we grasp the region edge by SO clip, then catch small ring of SO clip by another clip, then fix opposite side to the region, then restart the submucosal dissection like this. SO clip offer good visuality of submucosal layer, and we can dissect like this safer and easier, even with severe fibrosis. This is procedures of ESD of this case. This is ulcer bed after ESD. This is resected specimen. This is histological findings of resected specimen. This is intramucosal adenocarcinoma in tuberovenous adenoma. In Western country, severe dysplasia. In summary, tips of colorectal ESD for the case with severe fibrosis is as follows. To use of ST hood, counter traction by SO clip, and dual knife needling technique. This is Seto Island Sea in Hiroshima. This is atomic bombed dome in Hiroshima Peace Memorial Park. Thank you very much for your kind attention. Thank you so much.
Well, thank you, Shinji. That was a very inspiring lecture. And let's start with questions. Doug, do you want to start?
So it's interesting to listen to the presentations. The difference in the values, I think, about when ESD should be used, we're clearly not on the same page. There are some issues that have to do with pathology. To some extent, I think we are citing different risks of cancer. I wonder if we could reach agreement on how frequent for a particular type of lesion in a particular part of the colon you would have to have submucosal invasion for ESD to be of value, because I'm not sure that we have agreement even on that. And I wonder sometimes if the Japanese doctors would feel that even at a level of submucosal invasion, maybe for a particular morphology of lesion, it could be as low as 2 or 3%, and ESD would still be the best approach or a worthwhile approach. Whereas the Western doctors might feel that it should be higher than that, perhaps 10%. And I don't know that that we've really reached agreement, and that's part of perhaps the basis for the difference in approach and less willingness to undertake ESD in the West. I don't know if anyone has thoughts about that, but it's an interesting question to understand. We're all looking at the same data and drawing different conclusions about what the best approach is.
Right. Shinji, any comment?
Incidence of submucosal invasion is very important. However, we have magnification, EUS, various accessories, so we can diagnose exactly the SM invasion. So pre-diagnosis prior to endoscope treatment is very important. Using magnification and lesion morphology, we can diagnose exactly invasion depth of tumor or carcinomatous lesion, so we can select adequate treatment method. I have one question to Doug and Michael. In Western countries, you never diagnose intramucosal carcinoma. In this situation, is it important to distinguish between low-grade dysplasia and high-grade dysplasia? Because high-grade dysplasia is intramucosal cancer theoretically, so invasive potential it has. So please answer.
I'll go first, and then Michael can answer. So I think our approach is that if there's truly only intramucosal cancer or high-grade dysplasia, then the risk of lymph node metastasis is 0. And so we do treat that as a benign lesion that we have completely resected, even if we had removed it piecemeal. I think that the downside I would see in the U.S. is that U.S. doctors, they don't understand the distinction between intramucosal cancer and submucosal invasion in terms of the clinical risk of lymph node metastasis, and using a clinical definition of cancer as submucosal invasion. And so sometimes they'll respond to intramucosal cancer that's been removed endoscopically by thinking the patient needs surgical resection. So we think that there's more harm done by calling it intramucosal cancer than by calling it high-grade dysplasia. I don't know if we're always right. Maybe sometimes we're missing submucosal cancer in occasional cases because there is some risk of cancer after EMR and a pathology report that's benign. But in my experience, it's much lower than the 2.6% that was reported in the one study. And in our experience, it's about 0.3%. It's extremely low. I think I've seen your study, Michael. There were just a handful of cases in a couple of thousand EMRs. So those are my comments. But maybe I'm missing the point of your questions, Shinji.
Yeah, as you mentioned, pathological intramucosal carcinoma, high-grade dysplasia, never show lymph node metastasis, but clinical intramucosal carcinoma show potential of submucosal invasive carcinoma. So we reject en bloc.
So I think it's you're emphasizing the misdiagnosis of potential submucosal invasion to the intramucosal or high-grade dysplasia. Is that correct?
Yes. Yes.
Yeah.
So Mike, please do.
Yeah. So I think in the ACE study, now as I was saying, maybe there's 5,000 cases from like 8 centers, maybe half the cases or 2/3 from Westmead, and high-grade dysplasia is at least 30% of the cases, and cancer in follow-up is just a handful of cases, maybe 2. So I think the risk is very, very low. And we have to always bear in mind that, perfection is the enemy of the good. Like, we can't be perfect at everything. We have to be honest about what we're doing. But if we flip everything on its head and we say, well, all of this has got to be removed en bloc and so on, it's impossible to do with all the time constraints. And it may not add any benefit to the patient. I mean, patients can still be at risk in long-term follow-up. And the risk is, I wouldn't say infinitesimally small, but it's very, very low, very, very low.
Mike, could you clarify, when you do piecemeal EMR, how do you process your specimen? Do you just drop into the the jaw, or you pin
No,
it out
we
so that?
Yeah, so thanks, Norio. It's a good question. So for the longest time, we always pinned everything that was 2 centimeter or greater. We did that for best part of 10 years. And more recently, we haven't been as particular, but if we have a lesion that we're concerned about, we do. But I have to say that I'm rarely surprised by the pathology. I mean, maybe because of all the, huge experience, but I'm never, first of all, when the case is referred to us, we always get biopsy. People always send the biopsies. I never look at the biopsies. I just look at the lesion. The fellows say to me, oh, the biopsy. I said, I don't care. I just want to look at the lesion. And I just always look at the lesion myself to decide what the risk is and what type of lesion it is. I decide everything based on the imaging. And once we resect the lesion, it might happen once or twice a year that we say, gee, I didn't expect that. It's really unlikely that we're surprised by the pathology. But we did for a very long time pin everything so we could evaluate depth of invasion and so on.
That's very
but again,
important.
We're never surprised then. Yeah.
Great. Anyone last comment? I want to keep going on, but time is running out. Any speakers? Any last comment?
I just want to say I really enjoyed the session and appreciate the presentations. Congratulations to all of you, and thank you so much, Norio, for co-moderating with me. It's been a lot of fun.
Thank you so much, Doug. It was my honor, and thank you so much all the presenters for the excellent talk and their views. I hope that we can come along together to just separate those lesions who needs ESD and other device-assisted EMR or full thickness. We're going to come to the conclusion that, okay, we're going to do the same way. And I hope the mic is going to be telling us in the future, is, oh, I studied the ESD on the right side of the colon. Looking forward to hearing from you.
Can I make one comment? I think, Yutaka and Shinji, we've been having these discussions. I call them discussions for the best part of a decade, and we're much closer than we ever were. You agree?
Agree, completely agree.
We're making progress. That's fantastic.
Yeah.
Thank you so much. Excellent talk. And thank you so much. It's a great session.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Great to see everyone.
Good to see you.